Good afternoon, everyone. My name is Reem Tariq. I'm a senior project coordinator at the National Environmental Health Association, and at NEHA, I manage programs or projects that focus on federally unregulated drinking water, climate and health, as well as some of the emergency preparedness projects that we have. Thank you so much for joining for the second webinar in the Using EH Data webinar series. This webinar is titled From Data to Action, Arizona Public Health's Tracking Network. And we've got two speakers today. We are going to hear from Nikki Lajavardi-Kosh, as well as Shini Lin. Nikki is an environmental epidemiology program manager at the Office of Environmental Health at the Arizona Department of Health Services. And Shini is a toxicologist within the same office. Before we get into the webinar, I did want to highlight some housekeeping items. This webinar is being recorded. The recording to the webinar will be placed on the NEHA website about 2 weeks after the completion of the webinar. For the questions, we will be taking all questions towards the end of the webinar. But if you do have any questions that come up for you and you'd like to put them down, feel free to use the Q&A box or the chat box to put those, and we will address them towards the end. And I guess with that, I will pass it on to you, Nikki.
Okay, thank you. I will share my screen. Okay, are you able to see the presentation?
Yep.
Okay, great. So go ahead, Shini.
Okay. Hello, everyone. I'm Shin-Yi, and Nikki and I are from the Environmental Public Health Tracking Program at the Arizona Department of Health Services. So Arizona joined the CDC's National Tracking Network in 2017. Today, we are glad to have the opportunity to share our experiences with you in using the tracking data. Next. This is an overview of our presentation. So we will start with a brief background of environmental public health tracking and its significance in improving public health. Then we will introduce the Arizona Tracking Program, show you ways to utilize our Data Explorer, and share how we use the data to improve public health. After that, we will discuss our current effort on data modernization, health equities, and the data dashboard development. In the end, we will have a Q&A section for questions. Next. So before we move on, I want to define the word tracking. So CNN was one of my favorite TV programs for a long time. Most people watch the news to keep track current events. Tracking is a type of surveillance, which is closely watching someone or something to know what's happening with them. Next. So environmental public health tracking, it does what it says. It keeps tracking the environment that can affect our health, such as chemicals in our homes, in the air, and the water. It tracks health effects that may be related to environmental exposures, such as heat-related illness, birth defects, and the cancer. It also tracks the physical and the social environments, like traffic and the risk behaviors, for example, tobacco smoking. So in the field of public health, environmental public health tracking is the ongoing collection of health, human exposure, and the environmental hazard data, and keep them in one place. Next. CDC's Environmental Public Health Tracking Network is a public health surveillance supersized. It is a centralized database. It collects and combines environmental and public health data from local, state, and national sources. The data are collected and processed with the same standards so they can be compared across jurisdiction. Currently, 31 health departments participate in the National Tracking Network. Next. So why do we bring environmental and the health outcome data together? Life expectancy can vary up to 40 years, depending on the place where we live, work, and play. The air we breathe, the food we eat, and the water we drink varies from place to place. For example, living in an old building that has lead paint increases the chance of lead poisoning. Lead can cause serious health problems, especially in young children. The built-in environment is another example. I live in an area with many fast food restaurants and don't have many healthy food choices. It's less than a 5-minute drive from my house to Wendy's, McDonald's, Five Guys, Chick-fil-A, Freddy, Jack in the Box, Chipotle's. Okay, I guess Chipotle seems to be somewhat healthier than the other ones. Anyway, there are more than 10 fast food restaurants and only one grocery store. After a busy work day, I don't feel like cooking. On top of that, my kids and my husband, they don't really like my cooking either. So Wendy is my best friend and she provides an easy solution. Don't judge me on that. I try to give them a big bowl of grape tomatoes to make myself feel less guilty. Anyway, people who don't have access to healthy foods have an increased chance of obesity, which costs the country $150 billion a year, or 10% of the medical budget. Next. So why surveillance? Nowadays, many houses have a surveillance system. It tells you if someone breaks into your homes. It beeps to give you warning when the carbon monoxide level is high. Recently, I learned that the home surveillance camera could speak when I was walking my dog around the neighborhood. It's kind of cool. So when me and my dog enter the zone, suddenly it says, "Hi, you are currently being recorded." I got scared and my heart skipped a beat. The purpose of home surveillance system is to protect the house and the family. So we do the same in public health. We track to pick up unusual trends and use to gather the information to improve and protect public health. Much of what we do in public health relies on good, sound data. The tracking network keeps environmental and health data, outcome data in one place. That allows us to use the data and the time more efficiently. So we can easily pull data sets together to understand what may be going on between the environmental exposures out there and the health outcomes that we have seen. So we can start to look at the relationships and decide the resources that we need to put towards to addressing issues that may be of concern. Next. So after knowing the importance of tracking network in terms of public health, now we will show you what we have been doing in Arizona. Next. So this is an overview of Arizona Data Explorer. Our Data Explorer launched in 2018. It's a one-stop shop for different environmental health information. Next. So our Data Explorer has a visual dashboard that displays maps and the tables. So the map gives you a special overview and the table provides more detailed information. Next. The chart at the bottom shows the trend over a time frame. Next. On the left-hand side, there is a search and the query system. You can use keywords or the drop-down menu to search the data you are interested in using geography, content area, indicator, measure, and the year. So under geography, we have state, county, sub-county, and the public water system point data. Again, large geographic areas provide an overview, and the small geographic scales give more granular information. So under the content area, we have many data topics on health conditions, population demographics, the environment, and the exposures. Indicators, those are used to assess health status as it relates to the environment. For example, you see here the hospitalization due to heart attack is selected as an indicator because poor air quality has been linked to cardiovascular disease. On the other hand, people vaccinated for flu shots every year is also a health indicator, but it's not used here because it's less relevant to environmental exposures. There is also a layer list at the left corner at the bottom. So based on your selection, it can show hospitals, parks, or highways on the map. Next. So surveillance can be thought as eyes of public health. The information gathered from the tracking network helps us to better understand the connections between community health and the environment. Now, I'll show you a few things you can do with the tracking data. Next. So tracking data can be used to identify communities at risk. So Arizona's soil is high in arsenic. It's not an unusual thing to find elevated arsenic in groundwater wells. Rural communities in Arizona relied on private wells for potable purposes. So it's important to promote well water testing among private well owners. We have a well water testing program providing free testing services to well owners. Just like the public health work we do, funding is limited. So this board you show here, it shows the arsenic levels detected in groundwater wells throughout Arizona. To get the most benefit from the limited budget, our well water testing program used this information to prioritize its sampling efforts in underserved communities. So if you look at the table, it shows the number of wells tested, the range of detected concentrations, and the percentage of well above the maximum contaminant level for arsenic. So although it doesn't show readings for individual well, it gives you a general idea about the arsenic levels in groundwater in an area. For example, in the table, it shows that about 47% of the tested wells in Lower Gila Basin has elevated arsenic level. That's highlighted in kind of grayish blue. Our well program uses this information to conduct its outreach effort. This information, the groundwater arsenic level is localized data that is specific to Arizona, and it's not on the CDC national portal. Next. So the tracking data can also be used to guide intervention efforts. Arizona is hot. More than 2,000 people visit emergency rooms due to heat-related illness every year. Cooling centers are set up each year to mitigate the health effects from exposure to extreme heat. But the problem is that where should we set up those cooling centers to get the best benefits? Where should we promote the health awareness and the use of cooling centers? This board shows the number of emergency room visits due to heat-related illness at the county and the sub-county levels. So on the left-hand side is the county level. On the right-hand side, it shows the sub-county level data. So as we can see, Maricopa County has the highest number of emergency department visits. Within Maricopa County, Tempe, Maryville Village, and a part of the Glendale have the highest number of ED visits. This information can guide the cooling center planning and the outreach efforts. Next. The tracking data can also be used to inform policy and the decision making. So sanitarians conduct inspections to ensure food is safely stored, prepared, handled, and served. In Arizona, establishments should be inspected at least twice a year. This board shows the ratio of inspection to food establishments. So it shows what county don't meet the requirement. The chart shows the trend at the bottom. So as we can see that Yuma County hasn't met the requirement since 2014. On the other hand, Yavapai County has done a great job. So there are different things that can cause this trend, and such as lacking of staff or resources. So as the leading agency in the state, our food and safety program managers can use this information to guide their outreach efforts, resource distribution, work plan development, and the strategic planning. Next. After knowing the information on Data Explorer, like how we can use them, now we're going to show you how we collaborate with other programs or partners to develop an interactive risk map and the school heat policy recommendations. Next. So as we all know, lead poisoning is a public health concern. Recently, CDC lowered the blood lead reference level to 3.5 microgram per deciliter. Arizona is a targeted screening state, so not every child will be tested for blood lead. Blood lead testing is ordered through a healthcare provider. The problem is that no protocol can be used to guide providers on whom to test for lead. CDC's recommendation is that each state create its own guidelines for providers. Next. So to streamline the screening process, our childhood lead prevention program and the tracking program collaborated to develop a rapid assessment tool. This is an interactive mapping tool. Parents and the providers can enter an address and receive screening recommendations for that neighborhood. So this tool improves health communication. It allows our childhood lead prevention program to provide screening recommendation in high-risk areas for lead poisoning. Next. This is a closer look at the app. So if you type in an address in the search box, it will show on the map and give the screening recommendation. This recommendation is based on the age of housing, poverty level, and the demographic characteristics in the neighborhood, such as percent of the population speaking Spanish at home, and the race, such as percent of African Americans and percent of Native Americans. Now Nikki will tell you how the school heat policy was developed.
Thanks, Shani. Another way our group has collaborated with partners to use data for action is by addressing the public health burden caused by extreme heat. Our tracking program, along with the climate and health program at CDC, work together to use emergency department and temperature data to address heat-related illness among school-aged children. Arizona is one of the hottest places to live in the months of May through September. During these months, we see thousands of emergency room visits due to heat-related illness. And while Arizona is one of the hottest states, there has never been any formal guidance developed on extreme heat protocols for schools. As I mentioned, Arizona is one of the hottest places to live in through May through September. In Maricopa County, where more than 50% of our residents reside, between 2006 and 2016, we saw over 140 days of plus 90-degree temperatures. In 2020 alone, there were over 146 days with temperatures of 100 degrees or more in Phoenix, the capital. As the summer season would start, our office would get multiple calls from parents and school staff asking about guidance and safety precautions for schools due to the extreme temperatures. Our protocol has always been to share our tools and resources, such as the Heat Safety Index and Heat Safety Flyers and brochures. One of these is a toolkit for schools developed back in 2013. The toolkit provides resources for schools such as posters on heat-related illness, educational activities for students on heat-related illness, and training videos for faculty and staff. The toolkit also promotes the use of a heat index chart to make determinations about risk. During April through October, temperatures in the most populated areas of our state frequently fall within the blue box, meaning that these areas spend over half the year in extreme danger, or extreme caution zone. However, these recommendations are for the general population and do not take into account the physiology of children. The recommendations are also fairly general, such as heat stroke possible with prolonged exposure and/or physical activity, and some schools have a difficult time translating these into actionable guidance for what they should do during the school day. To develop more specific guidelines, we reviewed heat-related illness emergency room visits among school-aged children. We used this data to describe the burden of heat-related illness among school-aged children. This graph shows annual emergency department visits for heat-related illness during 2008 through 2017 by 3 age groups that correspond to elementary, middle, and high school. Over this 10-year period, there was an annual average of 193 emergency department visits for heat-related illness among children 5 through 19 years of age. You can see when we break this down by age group that up to 72% of cases in a given year are among children between 15 to 19 years. We know that not all heat-related illness in children result in a visit to the emergency department, but because there is no currently mandated reporting of heat-related illness, the emergency department data represents the lowest severity in the spectrum of heat-related illness that we can currently measure. We also looked at the data for seasonal patterns. This graph shows the total number of emergency department visits for heat-related illness among school-aged children during 2008 to 2018. When considering the risk to children at school, we are most concerned about the heat shoulder seasons right before school lets out for the summer in May and right when students return to school in August. You can see that August is one of the top 3 months when we see cases of heat-related illness. There are some school districts in Arizona that run on a year-round calendar and for which the temperatures in June and July would also be important. Beyond descriptive data, we also use our tracking source data to answer the more complex question of what is the relationship between weather and heat-related illness among school-aged children. We determined that we could address this question with a time series analysis using various meteorological variables and outcome data from the hospital discharge dataset. Results from a time series analysis, such as the example shown here, gave us estimates of risk at varying temperatures. With the help of scientists in the CDC's Climate and Health Program, we were able to make this chart, which shows a breakdown of where school-aged children heat attributable emergency department visits occur by increments of 5-degree temperature. It is also broken down by our climate regions of the state, with the basin and range being the warmest, transition zone, cooler area, and Colorado Plateau, our coldest and mountainous region. You can see the color coding of how we placed the red category where we saw the highest percentage and then implemented all other strategies before considering to move inside one below. The color coding in the previous chart corresponds to this table. Here you can see our draft tiered response using interventions from the scientific literature on activities to take for schools before the heat season, such as installing artificial shading, what to do at the lowest attributable risk, such as educating on heat illness. When risk gets slightly higher, do things such as move activities to early part of the day when it's cooler, and then in the highest risk category to advise to keep kids indoors. We pulled all this information together in the draft guidance document shown here. The recommendations including defining roles and responsibilities for staff, planning for educating students, parents, faculty, and athletic staff on heat illness, and defining trigger points for implementing various administrative controls. The document is currently being revised to a final version to which it will then be distributed to schools for feedback and evaluation. Looking forward, our program is working with CDC to achieve data modernization. Public health is entering a new era. Data modernization is an effort to update our outdated systems and the traditional ways we think about public health workforce and how we gather and analyze data. The vision is to develop world-class data and analytics to meet the needs of today's and tomorrow's health challenges across the public health community. Data modernization is about making data more timely, accurate, and complete to improve our understanding and we can get from it and the decisions we make. The Data Explorer, which acts as an open data portal, is an example of this. Going forward, we are planning to expand our Data Explorer by connecting with our agency-wide data portal, which will house all public health data for the entire agency. We're also working on improving data timeliness by using syndromic surveillance data, which is a form of near real-time emergency department visit data. Another way we're looking to make data more timely, accurate, local, and accessible is through developing data dashboards. A data dashboard is a tool used to track, analyze, and display key performance indicators, metrics, and data points. So far, we have developed dashboards for COVID-19 and heat-related illness. The COVID-19 dashboards were developed during the 2020 response. As COVID-19 became widespread in Arizona, easy to access information was needed about the presence in our state. In addition, pandemic responders needed ways to understand and track the state's healthcare capacity and ability to address COVID-19. Arizona's tracking program developed tools to help researchers identify locations of increased numbers of COVID-19 cases, help track the number of cases over time, and created resources for identifying vaccine accessibility and treatment locations. It made finding funeral homes and crematory services easier for hospital staff during death surge events. Shown here is a dashboard of the summary COVID-19 case counts. Our websites show very high usage of some of these applications. During January to October of 2021, the Vaccine Finder application was used more than 1 million times, and Testing Locations application was used more than 500,000 times by the public. Our team recently developed a heat-related illness dashboard using syndromic surveillance data. Syndromic surveillance data is a form of near real-time data that is reported by hospitals. Hospitals input information about chief complaint and discharge diagnosis, which allows for public health officials to monitor health trends in emergency departments. Every summer, our office gets requests from local county health partners and media for information about the current trends in heat-related illness visits. To provide this information to our county partners in a quick and easily accessible format, we developed a heat-related illness dashboard so that key metrics could be monitored during the heat season. These metrics include daily emergency department visits for each county by age group, gender, race, and ethnicity. This dashboard, which will include historic and real-time data, can be used for planning the upcoming heat season and planning for emergency response during the current heat season. We are deploying the dashboard this summer for internal use to our county partners to collect feedback and evaluate its use at the end of the heat season in September. The development of this dashboard will help rural counties who require assistance with syndromic surveillance and dashboard development and may not have the resources to do it on their own. Going forward, we're planning to develop more dashboards for important environmental health topics that we want to monitor on a timely basis. Along with improving access to data, we want to add more information to address health equity. Per CDC's definition of health equity is achieved when every person has the opportunity to attain his or her full health potential. Health inequities are reflected in differences in length of life, quality of life, rates of disease, disability, death, severity of disease, and access to treatment. Currently, our Data Explorer has a few topics that can address health equity concerns. This data includes information about demographics, health status, social vulnerability index, and socioeconomic status. The Social Vulnerability Index uses U.S. Census data to determine the social vulnerability of every census tract. The social vulnerability ranks each tract on 15 social factors, including poverty, lack of vehicle access, crowded housing, and groups them into related themes. Shown here is the Social Vulnerability Index developed by ATSTR for Arizona. Going forward, we're looking to include precise information that can explain health inequities, like developing a social vulnerability index specific to Arizona. We'll be working with our Health Equity Office to develop a SVI indicator that is specific to our state using the diverse characteristics of our state's population, taking those into account so that we can determine which segments of our population are the most vulnerable to poor health outcomes. As we move forward, we will be looking to add more information about social and economic factors that contribute to poor health outcomes as well onto our Data Explorer. So that concludes our presentation. We wanted to emphasize that tracking is more than just data. It's also about the education and outreach and the network of experts that are helping to translate the data into useful action. Thank you, and we can take any questions.
Thanks, Nikki. Thanks, Shani. Any questions for our speakers today? Just as a reminder, you can put in your questions in the Q&A box. I apologize for the chat box. I do realize that it might be disabled. I'm not quite sure why, but the Q&A box should be a way for you to ask your questions. If you would like to speak up, you could also raise your hand and I could unmute you. That way you could ask your question out loud. So we've got one question from Sean. What tech are you using for the dashboarding?
It's an Esri product. I don't have any more details on that, but I know it's based in Esri. Yeah.
And I think he's got a follow-up question regarding Tableau. Have you used Tableau as part of your dashboard or even generated any maps out of Tableau?
So the example dashboard I showed for the heat-related illness, yeah, that was created in Tableau. Our group is pretty new to Tableau, so that's the first dashboard we've made with it, so we're all learning as we go along. We haven't, I mean, the map that we created is the map of the county that shows the heat-related illness. That's the extent of our use of Tableau so far.
You've got a comment from James. He really appreciated your presentation.
Thank you.
And Nikki, Arizona Department of Health has been a tracking grantee for some time, correct?
Since 2017.
Since 2017. So you guys have gone through multiple phases and sort of updating your portal. What have been some of the challenges that you faced in developing the portal and also promoting it? I'm just curious.
I will speak more to the promoting it. It's been getting the portal in front of the right audience is a difficult task. What we've relied on a lot is social media, and I'm not sure that that's the best route. We can definitely reach it. We can get a lot of numbers to see it, but I don't know that all those people who are seeing it are using it. And the other side of that is also the difficulty in assessing how people are using the data. That's a very difficult aspect of our program. I mean, we have Google Analytics, so we're able to see how many people come to the dashboard or the Data Explorer, and we can see what types and where they're coming from, but how they're using the data, which is ultimately what we want to know. We want to make sure people are using data to make, evidence-based decisions. That's been a lot more difficult, and something I think all the grantees are always like working on to figure out. And also, and to the point of like how we develop the Data Explorer, we're always looking for feedback to make it, to enhance it and have it suit people's needs. But getting feedback can also be difficult. I mean, we've done one round of feedback through our listserv. So, but of course the response rate was kind of low, and we did get some useful information, but not as much as we were hoping to make some enhancements.
And I see Sean has another question here. It goes like this: if you are at the state level, do you have sharing agreements or make fully available your data with local health departments in the state for their dashboard or graph modeling? For example, like heat data.
So for us, we get the heat data from our hospital discharge group, and we have full authority to that data set because hospitals are required to report to the state. So in that case, the counties have a data sharing agreement with us to get information specific about their county for hospital discharge data.
Thank you. I'm also curious if I don't know if folks are using your dashboard, is there sort of like an evaluation portion towards the end as they're hopping off that web page where you might be able to capture some information on why they felt the need to access that data and how they plan on using it? Has Arizona Department of Health done any kind of work like that?
We've had discussions around that. We wanted to have like a pop-up poll come up either when they access or leave, but I think our agency has rules against that. So for the time being, we do have like a feedback button, I guess, in the top right-hand corner. I think something we need to work on is maybe just making that bigger and making it obvious to people, because we did get a comment that it's kind of small and hard to see. So we have some limitations around that, but if anyone has suggestions or you have suggestions about how we could do that, we would love to hear it, because it's definitely something we want to collect information about.
And I'm also wondering, it sounds like you have some information and, the health department would definitely appreciate more information on who exactly is using the data and for what purposes. Based on the information that you might have gathered in whatever way, are there any surprises on who's using your data and for what reason?
Nothing comes to mind as a surprise, really. Like I said, I think we're really lacking that information overall. I mean, through Google Analytics, we are able to see like where people are coming from, and we have seen some like international, I don't know if those were just accidents or something, or, people are doing looking at data in the United States from overseas as well for things. So, but that was kind of surprising, I guess, because we haven't necessarily done any promotion to an international audience per se.
Got it. That's interesting. I'm also thinking, and this is just a comment, would it be helpful to perhaps think of partners who might find the data useful and connect with them and do some kind of like a targeted approach of, I don't know if there are advocacy groups in Arizona that might benefit from knowing or having access to this data. Depending on what data is being collected and who it might be relevant to, I can definitely see some partners being interested. Have you folks done anything like that where you might have identified some potential partners?
The partners we've mostly worked with so far have been the universities, and that has been a great collaboration because it's a very useful tool for academic purposes, for sure, for college and graduate level research, and that has been very beneficial. Outside of universities, I think we're still working on developing strong relationships with our counties for them to use the data, and also maybe nonprofits. Just first of all, assessing like what are their needs, where do they get their data from currently, and if there's any way we can provide the information they need through our tool, we would be open to that.
Sure. Also, in follow-up to Sean's question regarding connecting with the local health departments, have you reached out to them and provided some kind of training on the portal? What's been the feedback from them on using data? Are they making data-driven decisions?
At this point, we haven't reached out to the counties for training specifically. Most of our trainings, I guess, have been more in-house. But it is something that we've been wanting to present to, because we know like the county environmental health directors meet on a regular basis. So I think our first step will be to introduce our program to that group and see which counties would be interested in having a training. and then we'll go from there.
Sounds good. So James, I'm gonna go ahead and allow you to talk. You might have to unmute yourself.
Can you hear me?
Yes.
Yes, thank you. Jim Rada, Jefferson County Public Health in Colorado. Just curious, as I just logged into or signed into your website, noticed that in the food establishments data that it's about 4 years behind. What is the process for updating the data in the tracking network? Colorado has a similar system, and that's always been a concern of ours, is that the statewide data seems to always be many years behind. What can you do, or how do you address the lagging data?
So for us, a big reason that we have quite a bit of lag right now is actually still because of COVID-19. Our dashboard or data explorer developer was focused on developing all those applications I talked about for COVID-19. So there really wasn't a priority to update the data explorer. And then now that her time has freed up a bit, she's learning all the different processes for updating all the different kinds of data sets we have. So we've been prioritizing, there are specific data sets that we have to submit to CDC first. And then there are other data sets that we have of our own choosing that we update as we have the data available. So right now it's just kind of a priority of getting those data sets that we have to submit to CDC updated first. And then we're going to move on to the other variables we have. And there's also a bit of a lag with the food safety data, and that all of that, the inspections are delegated to our counties. So we have to first get the data from the counties, get it to the state, and then once that's released from our food safety group, we'll have the data to update in our data explorer. So it really varies where because the data is coming from all different kinds of places and available at different times. But I guess the priority for us is having all our health outcome indicators that are required within tracking to be up to date first, and then prioritizing the remaining data sets as we see appropriate.
Thank you.
All right. I think those are all the questions that we had. I want to thank Nikki and Shani for taking the time and for that great presentation and for answering all the questions. I want to thank all the attendees for participating, and I want to thank everyone who asked really insightful questions. So thank you so much. And just want to remind folks that we do have another webinar. Webinar 3 is part of the series tomorrow. Let me confirm what time that is and go ahead and drop a link, registration link to that webinar in the chat box. If you haven't had a chance to register, feel free to do that. And as you are exiting out of this webinar, just know that there will be a survey that's going to pop up. Your feedback is critical. It helps us in improving what webinars we do offer. So please take a moment. It shouldn't take you more than 3 to 5 minutes max. So take a moment and take the survey and provide us with some feedback on what you'd like to attend for future webinars. With that, I want to thank the speakers again for taking the time, and want to thank everyone for attending. Take care, folks. Thank you.
Thank you.